I'm Dr. Daniel Rains. I'm the Chief of Gastroenterology for LSU Health Sciences Center in New Orleans, and I'm delighted to discuss our publication in gastrointestinal endoscopy, which is pharmacologic provocation combined with endoscopy and the evaluation of complex or refractory cases of gastrointestinal bleeding. The purpose of this study was to describe our experience of the use of medical provocation or pharmacologic provocation and the stimulation of bleeding in patients with refractory bleeding of obscure origin. And our practice, we encounter a large volume of patients with either suspected small bowel bleeding or obscure gastrointestinal bleeding as defined by patients with a negative evaluation by upper endoscopy, colonoscopy, video capsule endoscopy, and CT enterography. In some of these cases, patients have been found to have a defined bleeding segment where they have established small bowel bleeding, but the bleeding source remains obscure or unknown. In these patients, the suspected bleeding source is often a vascular lesion such as an angiectasia or doulofoy lesion, which might be definable only when actively bleeding. And so our thought process was that pharmacologic provocation with an antiplatelet or anticoagulant agent which might stimulate bleeding might be useful in stimulating bleeding so that the bleeding source could be defined and effectively treated. In our experience, we divided patients into three groups. The first was the provocation experience group, where they came or presented with a previous history of recurrent gastrointestinal bleeding, which appeared to be stimulated by previous exposure to an antiplatelet or anticoagulant agent such as clopidogrel or warfarin. And in those cases, we simply reinstituted or reapplied that agent in order to stimulate bleeding. The second group was a group of patients that had no previous history of stimulation of bleeding or suspected stimulation of bleeding by exposure to an antiplatelet or anticoagulant agent, and those patients were typically managed with a dose of clopidogrel, 150 milligrams, 12 hours prior to endoscopy in order to stimulate bleeding in order to define and treat the bleeding source. The third group was a group of patients with complex overt bleeding, where the bleeding source had been undefined despite exhaustive testing, often although the bleeding segment had been localized. So in a few cases, or several cases, the bleeding source had been previously localized to the proximal small bowel, but repeated examinations of the proximal small bowel by device-assisted enteroscopy had been run revealing, as was previous imaging by multi-detector CT. So these patients were evaluated for overt bleeding episodes when they typically presented with an overt bleeding episode, and if examination of the bleeding segment or examination of the entire GI tract was unrevealing, then they were kept in the hospital, transferred to the ICU, and then a full LSU protocol provocation procedure was performed, in which heparin was given IV intravenous over a 12-hour period and then stopped 6 hours prior to endoscopy, and this was combined with clopidogrel, 150 or 300 milligrams administered 12 hours prior to endoscopy, so that the procedure was effectively performed in the setting of clopidogrel exposure alone. In those cases, the bleeding source was defined in 6 out of 7 patients, and 1 patient had spontaneous resolution of bleeding and had no recurrent bleeding over a 2-year period since the chart review was performed. We feel that the results of this study demonstrate that enteroscopy and other procedures can be performed safely in the setting of antiplatelet or anticoagulant therapy, and the administration of a pharmacologic agent in order to stimulate bleeding might be useful to define the bleeding source. As a result of our study, we found that the diagnostic yield of each procedure or per procedure diagnostic yield in the experienced group was 53%, and the naive group is 27%, and in the diagnostic yield for the LSU full protocol group was 71% per procedure. So we feel the diagnostic yield may be worth the risk of the procedure. We certainly do acknowledge that the risk of administration of antiplatelet or anticoagulant therapy or an agent prior to endoscopy is not without risk, so this should certainly be weighed with the need or the potential for benefit for each patient. And typically we reserve this procedure only for patients with a transfusion requirement where they're transfusion dependent or required, again, repeated transfusions prior to consideration of medical provocation or pharmacologic provocation. We feel that these study results might be reproducible in the community and other academic centers where patients with refractory or complex cases of obscure GI bleeding might be better managed with such a pharmacologic provocation protocol. specifically, particularly in patients where the bleeding segment had been previously defined, say the stomach or proximal small bowel, where it's easily within reach of endoscopy, but cannot be defined unless actively bleeding. We certainly welcome any input from our readers regarding other agents that might be considered or other protocols that might be considered with a similar goal of stimulation of active bleeding combined with endoscopy for the management of these cases. And we look forward to comments from readers from GIE to discuss this case.